What else again?
Так, what else? What other questions? My difference, I have not very much time, so choose questions that are not clear to you at all.
The question is
All the practical. I do not have to.
from 17.
Number what?
17.
We did Kunio now.
Yeah.
It was also
From
starting
which?
from 18, right?
16? 16 is Kuno Sutra.
Yeah.
17
So we have
is
done
Danga Sutra.
Done it.
18 is operative approach to scanning nerve.
No.
Yeah, we didn't do it.
Operative approach to sciatic nerve. First of all, you have to say what is the projection line of sciatic nerve. Projection line of sciatic nerve. I want to remind you that the projection line of sciatic nerve is found out. We draw a line from the great
Is that
trochanter femur to ischial tuberosity. We imagine this line, yeah, and find the midpoint of this line. We find this midpoint and to the midpoint of popliteal fossa. This is projection line of sciatic nerve. Okay? Projection line of sciatic nerve. The incision to make approach to this nerve should be done along to this line. Just imagine that on skin we should do incision not like here or here, but along this line, depending which part, which portion of sciatic nerve we want to make approach. Proximal, middle, or distal. Okay? It should be longitudinal incision, not transverse. Longitudinal. Why? Because transverse incision gives smaller approach to smaller portion of sciatic nerve, whereas the longitudinal one gives us better approach for longer part of sciatic nerve. Is it clear?
Yeah.
After cutting the skin subcutaneous fat, superficial fascia, or generally we call it superficial tissues. Cutting these superficial tissues, we could find proper fascia of the thigh. That is called fascia lata.
Mashallah.
Fascia lata. If it is in proximal part, we also could see gluteus maximus muscle. Gluteus maximus muscle. The fascia lata is dissected, and under fascia lata we could find two muscles that belong to, be careful, that belong to posterior compartment of the thigh. Which muscles I mean? Biceps muscle of thigh on one side, and semitendinous and semimembranous muscles on another side. We just bluntly separate these muscles. Bluntly means not using scalpel, but just dividing them by hemostatic forceps. Separate these two muscles. Put Farabe's hooks. Why spatula? Spatula is used for
Bone.
periosteum.
Yeah.
We use Farabe's retractors or hooks to shift these muscles. These are hooks. And under these muscles we could find the sciatic nerve. Sciatic nerve. That's all. It will be the only trunk running down from gluteal radius down into the directed to the popliteal fossa. There will be no artery or vein beside this structure. Actually, on the nerve, on the surface of nerve, should be Arterial comitans nervis hiatus. Artery that supplies the
sciatic nerve.
This is very small, and usually while making a approach we do not damage this artery. That's all. The same we do, same procedure is the same if we need to make approach from like to the middle portion or distal portion of the sciatic nerve. In distal portion we do the same thing, but we should keep in mind that in the inferior third of the thigh, the sciatic nerve is divided into two branches. Tibial nerve that goes into the popliteal fossa and common perineal nerve. Common perineal nerve. So at this place, one could make mistake if surgeon do not remember about this division. He could accept this portion of nerve like sciatic nerve. So it is not sciatic, it's tibia.
Tibia.
Okay. And by the way, in some persons, it's individual variability. This division could happen superiorly. No, usually it happens in inferior third of the thigh. Have questions?
No.
What patient's position should be?
Lying on anterior
Lying
region.
face down.
Face down. So when we have to explain this, like we have to draw or we have to show on body?
You have to explain everything. If you could draw,
Indication.
it's very good. Indication for a surgical approach to sciatic nerve. The indication is any operation on nerve. What kind of operations on nerves are usually performed?
Like radical light.
It could be damage or injury of the nerve, or so-called when the nerve is involved into the scar. Like this is nerve, and here there are scar tissue. If nerve is involved into scar tissue, it is deformed. Nerve is deformed. It causes pain, constant pain. Then we do neurolysis. Neurolysis is such operation that implies making free this nerve from this scarring tissue, from these adhesions. Okay? Next. To the radial nerve on the arm. Okay. The radial nerve on the arm is situated in which compartment? There are two compartments on arm. And two anterior.
Posterior. Posterior.
Posterior compartment. Posterior compartment. This is posterior aspect of the arm. Posterior aspect of the arm. This is the deltoid muscle. This is humerus. This is projection of, not projection, like just reflection of radial nerve. Radial nerve is situated
Oh my god.
radial nerve is situated in the posterior compartment and lies in humeral muscular canal, also called canalis nervi radialis. Yeah?
Да.
Again, for approach to any nerve or artery or vein, first we have to remember projection line of the structure. Projection line of radial nerve first of all, now we are wanting to make access to radial nerve in humeral muscular canal. So look, this is deltoid muscle. Yeah, here should be triceps muscle, right? So the deltoid muscle, this is we call it the posterior margin, if you remember,
Yeah.
posterior margin of deltoid muscle. First, anteriorly we have anterior margin of deltoid muscle. So the posterior margin of deltoid muscle, midpoint,
Okay.
the midpoint, is drawn down to the, like this is arm. We divide arm onto 3 equal portions.
Open with one.
Lateral margin of arm onto 3 equal portions. And we say the inferior point should be on the border between inferior and middle thirds. Is it clear? From first point to second point, we draw this line. This is projection line, a line of radial artery. Radial artery. Okay, now access, procedure, technique, what we usually do. Again, the incision should be done along to this projection line. We do incision, we dissect all the superficial tissues. And then we meet the proper fascia of the arm. Proper fascia, brachial fascia.
On lateral side, right?
Sorry?
On lateral side we make the incision.
Incision?
Yeah.
It depends. It could be done here or here. When we reach the brachial fascia, we dissect proper fascia, brachial fascia. We dissect it. We dissect, and then we could see the triceps muscle. And between the heads of triceps muscle, again, bluntly separating these heads of the triceps muscle, we could separate them using the Farabe's hook, shift them, and could enter deeper under the triceps muscle, toward the bone, toward humerus. And as soon as we do it, we could find the radial artery that lies onto
The humerus.
In a special groove. Yeah? So
Radial groove.
sulcus nervus
Radial.
the radial nerve is followed by which artery? No, brachial artery is posteriorly, centrally.
Deep arterial form.
Deep artery
Of the arm.
Yeah, or deep brachial artery. No, that's all. Have questions? Так, technique of puncture of subclavian vein. Well, the subclavian vein is punctured for a few indications. The main indication is to inject drugs when we need to inject some solutions, not once, but a few times. Or we want to do it during a few days. Or if we want to inject MASH solution, we do not use peripheral veins, like median cubital vein. Usually we do not use them. We use the
Central.
subclavian vein. This vein is called central vein. It has such name, central vein. I mean, it's not the anatomical name term belonging to subclavian vein, but according to its size, it is called central vein. And in clinics, they usually say, right, to inject some solution, 400 milliliters, in central vein. It means in subclavian vein should be injected. Or one more indication if we need to inject MASH solution immediately, like in case of shock. Well, how it is performed? The subclavian vein is situated just behind clavicle. Actually, there are many points for puncturing subclavian vein, and all these points are called, are divided into two groups. The points situated superiorly to clavicle, called supraclavicular approach, and inferiorly to clavicle, we call it infraclavicular approach. The most frequently, the infraclavicular approach is used, and this point is situated where this pricking should be done. Just we find the middle of the clavicle, along inferior margin, and we put a needle in this point. And this needle should be directed toward sternoclavicular joint. It is directed toward sternoclavicular joint. Anybody has pain? Sorry. Could I show one? I palpate clavicle. I find clavicle, inferior margin, midpoint. Here I find midpoint, sternoclavicular joint. You see the direction of the needle, the angle under which the needle is inserted. We prick. If we do it in this direction, the needle finally will reach the subclavian vein and prick it. As soon as we prick it, we get blood into the syringe. At the moment of pricking, actually at the moment of this procedure, when we do this procedure, we ask patients to stop breathing. Yes. But to stop breathing at the moment of breathing in. Like we ask to breathe in and stop. And stop. Why? When we ask to breathe in, in thorax, the pressure increases in thorax. It increases, and as we make puncturing, it prevents leaking air into the vein. Conversely, if at the moment of pricking subclavian vein, patient breathes out, it makes lowering of the pressure in thoracic cavity, and lowering of the pressure in thoracic cavity makes vessels expand, and as vessels expand, the intravenous pressure also decreases. That's why air could easily leak inside. That's why, to prevent this complication, you understand that if air enters the vein, finally it will cause pulmonary embolism. Yeah. To prevent it, we ask patients to breathe in and to stop. And we should do it faster, right? Not to let patients wait a few minutes. So not breathing. We do it faster. If everything is done correct, good. Though sometimes the most dangerous, actually the most frequent complication could be damaging of the artery. Which artery? Artery that is situated just behind the subclavian vein. That is
Subclavian artery.
Subclavian artery. This complication may happen if the direction of needle is not correct, or if patient's position is not correct.
So what is the position?
What's the position
So what's
of the patient?
of the patient? Position.
It should be supine position, yes, or patient's position should be supine, straight without any pillows and so on.
This one is fine.
And what actually physician should do when the artery is pricked? We take out needle. How we understand that the artery is pricked? In the syringe occurs blood. Oxygenated.
Yeah.
You could see we can distinguish, easily distinguish venous and arterial blood. We could see. It means we take out the needle and press on this area. Press on this area a few minutes, 1-2 minutes, to close this opening. Usually it's enough to make thrombosis at this small opening on the vessel, on the wall of the vessel. And after that, we do it again once more correctly to make puncture of the vein. If occasionally this puncture happens and we could not stop and we have signs of bleeding, sometimes some drugs could be applied, could be needs to stop the bleeding. There is one more point also frequently used and also easily could be done. This point is situated between the two tendons of sternocleidomastoid muscle. Here, actually, this is subclavian. And here, just behind sternocleidomastoid muscle, we have internal jugular vein. So pricking in this area, in this point, we could prick internal jugular vein or subclavian vein, or sometimes even we could reach the brachiocephalic vein. It doesn't matter because all these veins are central veins. Usually after pricking, as we need to do it a few times, I mean injection, intravenous injection. Usually after pricking the needle, we put a small catheter into the needle. A small catheter, like, I don't know, have you ever seen in hospital? Or no, it's a common procedure in any hospital that is performed. When any vessel is pricked, any vessel is pricked, we put a catheter, thin catheter, inside. As soon as it is inside, and we push it further. Depends on which vein we make this. This is called catheterization. We put it into the vein and then remove the needle. Remove it. This is catheter. And on skin, the catheter is fixed to skin. Fixed. So that this catheter could be used instead of needle, not to prick it each time, yeah, and to damage to make a trauma to this vessel, yeah. To use this catheter each time, we need to make injection. And of course, as we deal to venous blood, the venous blood usually has the property to coagulate, right? each time when we finish injection or taking blood for analysis, each time we add into the catheter, we add a very small amount of
Heparin.
Yes, to prevent clotting blood into the catheter and into mainly into the catheter. Because if we do not do it, next time, like 2 hours after previous injection, we could try to do it and there will be thrombus. We could not make injection, it will be blocked. Or could happen worse things, like we could press and this thrombus could tear and go into the venous blood, into the bloodstream. Okay? Так. Ну вот, what else? Operative approach to the ulnar artery. To the ulnar artery. This is arm, this is forearm. Could we do surgical approach to ulnar artery on arm? Why? Why?
Yes, I think we can. In the bicipital groove. Yeah?
Of course, there is no ulnar artery on arm. Yeah? Ulnar artery originates after bifurcation of brachial artery and cubital fossa.
Okay, I was looking for ulnar.
Again, we need to know the projection line of this artery. And the projection line of ulnar artery, if you remember, this projection line is different for upper portion and to lower portions. I want to remind you that for upper portion, the projection line is drawn from the midpoint of cubital fossa to the if the medial margin of forearm is divided into equal portions, so the point is on the border between proximal and middle thirds. From midpoint of cubital fossa to the border between proximal and middle thirds on medial margin of forearm. This is for upper third, the projection line. When you answer on surgical approach, obligatorily, first you should tell projection line. Okay, and then technique, which tissues we dissect, what muscles we shift, and so on. It's very important. And for lower third, the projection line is drawn from medial epicondyle, down to the, here we have pisiform bone. Pisiform bone.